Naloxone, commonly known as Narcan, it is an opioid antagonist. So the way it works, it is a competitive antagonist of opioid receptors in the body. It will block, and the main reason we use it is to reverse the effects of an opioid pain medicine overdose. So it is, because it is a competitive antagonist, it has a higher affinity for those opioid receptors than does most opioid medicines like morphine, fentanyl, all those good ones. So it blocks them, or it knocks them off the receptor sites and then binds to it, so it blocks the effects. Pregnancy class for it is C. There we go. Drug interactions, it is incompatible with bisulfite or alkaline, so we want to avoid that. Use different IV. I feel like we missed something there. Yep. Indications for it, yeah. Let's start with this. Opiate overdose, and then CNS depression, whether it's respiratory depression, decreased level of consciousness, or coma, and we're not sure what's causing it, then we can use Narcan for that, just to try to rule out an opiate overdose. One way that we can tell is if a patient has pinpoint pupils, that typically leads us to believe that it is opiate-based. So if they have pinpoint pupils, we'll give Narcan for it. Contraindications, not really any contraindications, but we do want to use caution with anybody who has a narcotic addiction. And if we suddenly reverse all the effects of those narcotics that they've been used to taking, we can cause severe withdrawal symptoms and a lot of bad stuff, and seizures can go along with that as well. Some adverse reactions that we want to be mindful of: restlessness, seizures, dyspnea, pulmonary edema, tachycardia, hypertension, nausea, vomiting, diaphoresis, and then of course cardiac dysrhythmias or cardiac arrest is always possible. The biggest one that we have to watch for, the most common one that I've seen anyways, would be nausea and vomiting and restlessness. Like we mentioned, it is incompatible with bisulfites and alkalines. The dosage for most adults is going to be 0.4 milligrams up to 2 milligrams, IV, IO, IM, IN, however you need to give it. For the kiddos, we usually start at 0.1 milligram per kilogram, and the max is going to be 2 milligrams. So they usually get pretty close to or the same as an adult for the dosing. Starts working in less than 2 minutes. It's pretty quick. Peak effects varies. It's also based on what medication it is counteracting, and it does last up to 1 hour. So something to keep in mind with it, if someone has had respiratory depression and maybe their SpO2 levels are low, all that good stuff, we want to pre-oxygenate first. We also want to be mindful if a patient is taking a very long-acting opiate, some of those extended release medicines, then we might have to repeat dosing because it only stays in the body for about an hour and it is a competitive antagonist, then we might have to repeat that. It's always a good idea on the dosage, start small, start at 0.4 milligrams, see if you get any effect with it, then bump it up a little bit, and that way you can kind of sometimes prevent those withdrawal symptoms, prevent them from throwing up everywhere, prevent the restlessness. We really just want to use this to restore respiratory drive. That's the main goal in it, so get those patients breathing on their own again. So that's why we want to start small on our dosing and then work our way up as needed. So there you go.